equation. So take the systolic blood pressure, that is whatever's on top, that's your systolic blood pressure. Subtract your diastolic pressure, that's on the bottom. And then take 1/3 of the difference. So if it was 120 over 80, it would be 40. 1/3 of 40 gets 13.33333. Then add diastolic back, so you'd have a mean arterial pressure of 40 plus 13.3 or 53.3. So you can also, this is what's in the arteries all the way out. This is what you would measure when you put a blood pressure cuff around a person's arm and constrict the blood flow and then let the pressure off until you get the blood flowing underneath. And first it comes through into an empty vessel and it's turbulent, so you hear a snapping sound. Once the blood can flow smoothly again, then the sound usually disappears, and that's what you take as the diastolic or filling pressure. You can also do the mean pulmonary pressure, and of course you can't strap a cuff around their chest and pump that up. That wouldn't be how you do it, but you can insert pressure sensors through vessels and get into the pulmonary circulation. Or you can put it into the right heart and get indication of what the heart has to pump up above to get blood out. And the right heart generally has to get up to over 25, around 25. And then diastolic, it would be somewhere around 8 to 10 millimeters of mercury. And the units are always mm for millimeters, and Hg stands for mercury, millimeters of mercury. So pulmonary circuit, your right heart has very short distance to pump the blood, and then immediately the blood vessels will start to branch and follow the airways out to where gas exchange is going to occur. And gas exchange is occurring in what are called alveoli, which are little grape-like structures, really, really tiny grapes, but they're full of air that's been inhaled, and then they share a basement membrane with a blood vessel, so you get a very thin layer of tissue and connective tissue, the endothelial cells of the alveolus, endothelial cells of the capillary, and then some connective tissue binding them together, not with some surfactant in here are your fusion barriers. O2 has to get through to get to the hemoglobin. CO2 has to get through to get from the blood to the alveoli to exhale. And the actual respiratory part of this is for another chapter. Once you get the blood oxygenated, then the blood vessels, the capillaries will form venules, and the venules will form veins, and the veins are going to take pretty much the shortest distance from wherever gas exchange occurred right back to this opening it's called the hilus, and then to the left heart. So if you were to count the number of and follow the pathway of the arteries out to gas exchange area, they would be exactly following the route of the airways. So every time the airways divided, the arteries would divide until they get to the arterioles and then the capillaries. And then the capillaries would multiply and surround each alveolus. You're not going to just have one capillary per alveolus, but a whole ball of capillaries around the alveolus. And then the veins start on the other side of the capillary bed. They're going to join together, but they're not going to follow the airways back. They're just going to join together and take the shortest distance back to the exit from the lungs. So the arteries have to enter and the veins have to exit at this opening in the lungs called the hilux. Of course, reminding yourself of what vessels you have to learn for the examination, you can use this figure, but this figure is not going to be on the exam, because in order to get it big enough to identify blood vessels, it's going to take up the whole page, and then you can't put a question on the page. So just, you can use this for review purposes, but don't study it as though, oh, she's going to have this on the exam. No, it's not going to be on the exam. The flow charts that come in your chapters, they're really good study points, because they tell you what the artery's name is, and then they tell you where it's distributing blood and what tissues it's distributing blood to. A lot of the names of the arteries are, they could be named for a bone, they could be named for an anatomical region, and so they're, if you know your bones and you know your anatomical regions, a lot has, you already learned a lot about your blood vessels. So these types where it's just either the head or the torso, or no head and just the torso, those kinds of figures, expect to have those on the exam. The first branch of the aorta, you don't see it here, but those will be your right and left coronary arteries. Right after the semilunar valves, right and left coronary arteries come off. You forget after you studied the heart about those coronary arteries, but they're there, and they're the first branch of the aorta. The ascending aorta doesn't give off any other blood vessels, but the arch of the aorta is going to give off 3 main blood vessels. The one that is going towards the right side of the body is going to have vessels that go to the head, and then vessels that go to the neck region, and then under the clavicle, and then through the axilla, and then down the upper extremity. So this blood vessel, since it is going to give off the other, divide to form the other distribution arteries, it's not named for a particular direction, rather it's named for the fact that it is a trunk that is going to divide further. So we have a brachial, meaning it's going to the arm, and then also cephalic, which means it's going to the head, trunk. So a brachiocephalic trunk on the arterial side. It's going to, first branch that goes up towards the head, this is going to be your right common carotid artery. Common means that when you see that term, that means it's going to branch and form some other vessels. Sometimes those vessels have the same name, but they're headed for different locations. In this case, the common is going to branch and form an internal and an external carotid artery. So the right common will then branch, and we'll see it on another figure, to form 2 more vessels that have the term carotid in them, internal, external carotid. Next branch still goes to the head. This is going to go up the back of the neck. You probably all know where your carotid artery is. That's where you feel your pulse on the side of your neck. That's your carotid pulse. Vertebral goes up in the back. If you remember all the way back to last semester, cervical vertebrae have these openings in the transverse foramen. And that's where your vertebral artery will go, and also where your vertebral vein will bring blood back through that. So it's going across very exposed area, not very thick muscle back there. That's your world's strongest man, and then you got these big, huge, thick necks. But for the average person, not a lot of muscle back there, so you need a little more protection for these vessels. Carotids got nice sternocleidomastoid and some other strap muscles in the front here. You got to kind of press in between there to feel the carotid pulse. Then we've got this another trunk, and this is called your thyrocervical trunk. We'll see it on another slide, another figure. This isn't in that label. I just inserted it here to get you started in thinking about this. Is going to the thyroid area, also to the cervical region. It's going to take blood to your spinal cord. A lot of blood vessels will take blood to your spinal cord because your spinal cord is going to go down to L2, L3, and then your cardiac from there on. But thyrocervical trunk is one of the first that gets blood to the spinal cord in the cervical area. Got a right one, got a left one. And then the blood vessel just changes its name from the brachiocephalic artery to subclavian, and then axillary, and then brachial artery, and then down at the elbow region, it's going to form some vessels that are named for bones. So clavicular region, subclavian, axillary region, axillary, brachial region, brachial artery. The next vessel that comes off the aortic arch is your left common carotid. There is no left brachiocephalic trunk. So it's only a trunk on the right, so we don't bother to say right. We only include right if there is another one on the left. So we have a right common carotid, now we have a left common carotid. Left common carotid comes off the aortic arch. Right common carotid does not. Comes off the brachiocephalic trunk. And then we've got vertebral. So that is coming, next one we have the left subclavian, and then we've got vertebral artery coming off that, and thyrocervical trunk, the next branch of the subclavian. Subclavian, then becomes axillary, becomes brachial, and blah, blah, blah down below. This is X-ray. The blood vessels have been filled up with contrast media so that when you take this picture, the blood vessels stand out very distinctly against the other soft tissue. So we've got the aorta, ascending, aortic arch, brachiocephalic trunk. First vessel off of that's ascending to the head is your right common carotid. And then we've got a mess of stuff here. It's kind of hard to identify, but we've got one trunk that's coming off here with a lot of little vessels, another trunk coming off here with a lot of little vessels. So that is thyrocervical trunk. You can see clearly the vertebral artery on this side, but the vertebral artery is running through this mess of smaller vessels, so you can see it up here, but not so clearly down below. What you see clearly on this, but not on the previous illustration, but on the later ones, is that after the common carotid leaves, then you have a descending vessel that's entering the thoracic region, and that's going to be your internal thoracic artery. And there will be one on the left, but that's kind of obscured. It's right here, but it's obscured by the tissues on that side. So So next after the trunk is your left common carotid, then subclavian, left subclavian, and coming off the subclavian, your vertebral, and then your thyrocervical trunk. When you get down to you got the brachial artery coming down, you're going to have some smaller vessels coming off. You're going to have ulnars coming off the brachial up above, and then you're going to have a main ulnar artery down below. This smaller ulnar is going to come around, and then it's going out, it's going medially, and then it turns a corner at the elbow and comes back in the opposite direction. And when things do that, then they're referred to as recurrent. So if they're going in one direction and they turn and go back in the opposite direction, we call it a recurrent artery. So you have anterior ulnar recurrent and a posterior ulnar recurrent, and that's what that label is all about. Here you've got radial artery. When you come down into the palmar region, you're going to have anastomoses between the ulnar and the radial arteries. And you're going to have deep palmar anastomoses, they're called arch just for the shape, and then superficial palmar arches. When you use these anastomoses and you have all these digital arteries constricted, then you are bypassing the blood is bypassing the finger. That's what happens when the ambient temperature is really cold. You want to keep warm blood for your brain and for your other internal organs. You can sacrifice your fingers, and down in your feet, you can sacrifice your toes to frostbite. Before frostbite happens, these sphincters will actually open and you rewarm your fingers. But the longer you're exposed to the cold environment, the more the vasoconstriction is going to be on a long-term basis, and lack of oxygen to the tissues, that's when you get the gangrene and you start to lose the fingers and the toes. So that's what palmar arches are for. They're a way to bypass the blood flow and actually get right into the deep veins and have the warm blood go back into your thoracic area and then up to your head. These internal thoracic arteries, I've made a little note to the side there that those are used for coronary bypass surgery. If you have arteries on the front of your heart that are blocked, and there are just a couple areas that are blocked, you don't have to open the whole chest up. You can go through the ribs, and you can take these blood vessels and reattach them to the heart instead of having them go to their tissue. You just put them, reattach them beyond the block in the heart, and then you've got oxygen delivery to the heart again. You don't have this massive injury to the chest region. You don't have to pop all those hyaline cartilage joints, the cartilaginous joints apart. Don't have to open the chest. You just have to do this I was going to say laparoscopic. I'm not sure if that's specific to down below, but anyway, it's that endoscope that they insert, and they can visualize and do that surgery. So flow chart tells you where everything is going. So right internal thoracic that we were just talking about, it is going to the skin and muscles in the chest. So you can take one of its tributaries and reroute it to the heart. Heart is more important than skin and muscle in that area. And as those tissues are getting starved of oxygen, more blood vessels will form and go to those tissues. So they can be starved of blood for a short period of time. Your heart can't afford to. It's also also going to your mammary gland and then to the pericardial sac. So you can redirect some blood to the heart and not lose any critical blood flow to an organ that's, these are less important organs than the heart. So general locations where things are going for all of these. You notice the vertebral artery goes through your spinal cord, the thyrocervical trunk, it also is going through your spinal cord but not saying it there. Everything, all the locations on the right are identical for the left side as well. So that our common carotid, we're seeing it on the right. This area where it splits, that's called a bifurcation. So bi meaning two routes from that point on. The internal carotid, if you follow that, it's going inside the skull and then it becomes shadowy. That's indicating it's inside the skull. The external carotid is coming out and it's shown darker on the surface of the skull. So external carotid is going to your scalp, to your hair follicles, to the tissues on the outside of your skull. But internal carotid is going to your brain, to structures inside. The internal carotid is going to have a dilated area, and that's called a sinus. It's called the carotid sinus. That has a pressure sensor function. It's a mechanical stretch receptor located in the wall of the blood vessel. It's looking to see, is the blood pressure that's coming by going up above what's normal, or is it going down below what's normal? It's hooked up to the glossopharyngeal nerve, and that will fire action potentials to the brainstem, to your cardiac center, and you'll make appropriate adjustments to your heart rate. If your blood pressure is going up, then you want cardiac output to go down. If your blood pressure is going down, you want cardiac output to go up. If you want your blood pressure to go down, dial back sympathetic and jack up parasympathetic. So contractile force goes down, heart rate goes down, cardiac output goes down, and your blood pressure goes down. If your blood pressure is going down, first thing you do, jack up dial back the parasympathetic so that your heart rate jumps up. If you still need more cardiac output to get the blood pressure up, then you stimulate the sympathetic nerves to increase contractile force. So this is referred to as a baroreceptor. It's a mechanoreceptor. It's mechanically stimulated by changes in blood pressure. In between the internal and external carotid, you've got some special cells there that are sensing the oxygen and CO2 concentrations, hydrogen ion concentrations in the blood. And those are chemoreceptors. They're measuring the gases, the particles in the blood. They're called the carotid body, as opposed to sinus. Sinus means a dilated area. Body is referring to a chunk of cells. These are hooked up to cranial nerve number 10, and they will also fire to the brainstem. If you see an increase in CO2, you increase cardiac output, but you also increase respiratory rate so that you exhale more CO2. You see a drop in CO2, then you dial back on your respiratory rate, hold, the breath is held longer, CO2 builds back up. So chemoreceptors, they're hooked up to the heart, but indirectly from the brainstem, but they're also modifying respiratory function. So, picture of where the vertebral artery goes through the transverse foramen. It will go through the foramen magnum and then go up across the back of the brainstem. And we'll see on a later figure exactly what arteries it will turn into when it gets inside the head. Thyrocervical trunk, we've got inferior thyroid artery. It's going to go through your thyroid gland. And then we've got transverse cervicals going to structures in the neck region. And then another one that's going to go back to the back region. That's going to be under in the scapular region. So internal, external carotids, they're important because they're delivering, the internal is taking blood to the brain, external just to neck as it's passing by and then outside of the skull. The internal carotid also gives off an ophthalmic artery that's going into the eyes. It goes into the eyes to the retina, but it also comes out of your orbit to this frontal area in between your eyes. I saw a really weird article, couldn't believe it, but the Korean gentleman was having fat injected into this region here because he didn't like the creases between his eyes and the frown lines. And apparently they injected the fat very quickly and happened to have their needle in the artery and put a bolus of fat into the artery that went back to the ophthalmic branch of the arterial system. When that fat went out into the retina and he went blind. So really strong consequences to having so much vanity that you can't stand these little vertical lines between your eyebrows. Yes. So other branches from the internal carotid besides the ophthalmic, and then out here, arteries, blood can flow in any direction. If you inject fat fast enough, it can flow through those arteries in any direction. You got anterior cerebral. After it enters and goes up to the middle of the brain, it's going to join with blood vessels that are joined to the vertebral arteries, and they're going to make a circle in the middle of your brain, and they're going to connect in the front via a little connection called anterior cerebral artery and then an anterior communicating artery. This vessel actually goes through all your frontal lobes, and middle cerebral artery is going to all the lateral parts of your brain. So only your vertebrals are going to the posterior parts of your brain. So this is the circle that I was referring to. It's called either the cerebral arterial circle. Older books and occasionally even newer books will call it the circle of Willis. You got your internal carotids coming in, and they'll give off your anterior cerebral that will go all the way out to the frontal lobes. And then the little communicating artery that joins the two anterior cerebral right and left together. And then back here, we've got a posterior communicating artery that is joining with these posterior cerebral arteries, which are a branch of this basilar artery, which is formed by your two vertebral arteries that come together. The vertebral arteries are entering, they're coming through the transverse foramen. They enter the foramen magnum and join together, form the basilar artery, and that will give off posterior cerebellar, posterior and then pontine arteries, and then you have posterior cerebral coming off before it gives off these little branches that are going to join up with the internal carotid. So this is your circle of Willis. It consists of the posterior cerebral, posterior communicating, carotid, anterior cerebral, and anterior communicating arteries. This middle cerebral artery that is headed out to the parietal and temporal lobes, that is a very important part of this circulation as well. Of course, any part of your brain can afford to lose it, but should you have a blockage or you don't have one vertebral artery but you have all the others formed, then blood can flow through the circle, come back retrograde, and then get out to those parts of the brain. If you have a block here, blood can flow around and come back to the posterior parts of the brain. If you have a block there, no problem, because it's just communicating right and left sides. But if you had a blockage here, blood could flow around, come through, and still get to the frontal lobes. So it's important that you have this cerebral arterial circle intact. And here they filled it with a red latex. These are the vertebral arteries. They're joining together to form basilar, and they kind of distorted. The brain tissue wasn't held nicely in position when they filled it with the latex. So you got some distortion. That posterior cerebral and then posterior communicating is kind of distorted here and not so distorted on that side. You've got internal carotid kind of pull over on top of the pons there, and then the anterior cerebral coming off and going towards the front, kind of tortuously going around to the front there. So another way to look at it is to do angiogram. Fill, again, the blood vessels with a contrast media so they show up as bright white when you take the x-ray. And you can follow the internal carotid in and then branching to go forward, the anterior cerebral going out to the frontal lobes here, the ophthalmic branch going out to the eye there, that middle cerebral coming off the carotid, and then going out to your parietal lobes and part of your temporal lobe. And then the posterior part will be innervated or have blood flow from your vertebral arteries. But they injected the contrast dye into the carotid so the anterior vessels show up more than the posterior vessels. Another way to look at your blood vessels, again, with you fill the arteries with the latex, and then you allow beetles or some erosive kind of chemical to eat away the tissue, the neuronal tissue, and you're left with these plastic casts. So beetles are actually better because they'll eat all the dead tissue, and the chemicals might damage your latex, but the beetles won't. They just will ignore it and eat until they have all the tissues away from the latex. So that's what your vascular system looks like inside your brain, which is pretty good. Okay, so we'll pick up with this slide.